The following is a presentation on the basics of Achilles tendoscopy concerning the surface anatomy, port replacement, and diagnostic evaluation. With the use of a sterile marking pen, the relevant anatomical landmarks are identified and marked out, including the medial and lateral borders of the Achilles tendon, the sural nerve, and the proximal medial and distal lateral portals. The distal lateral portal is positioned just medial to the lateral border of the Achilles tendon, 2 to 3 centimeters proximal to its insertion at the calcaneus. The proximal medial portal is positioned lateral to the medial border of the Achilles tendon, approximately 7 to 8 centimeters proximal to its insertion. These portals allow access to the entire length of the Achilles tendon while minimizing risk of iatrogenic injury to the sural nerve. 10 milliliters of sterile saline is injected into both portals. Using a number 11 blade, a 2 mm vertical skin incision is made at the distal lateral portal. Subcutaneous blunt dissection is performed using a mosquito clamp, followed by insertion of the trocar and exchange of the obturator for the endoscope. The fluid pressure is typically set to 30 to 40 millimeters of mercury. Any cicatrized scar tissue, adhesions, tears, or a tethered plantaris tendon are identified. If any pathology is present, the proximal medial portal is established under direct visualization using a spinal needle followed by a 2 mm incision using a number 11 blade. A 2 mm shaver is inserted into the proximal medial portal to debride the impinging tissue between the paratenon and Achilles tendon. A freer elevator is used to circumferentially release any adhesions between the tendon and paratenon. Under direct visualization, microperforations are created within the substance of the tendon using a spinal needle in order to stimulate neovascularization. If a Haglund's deformity is present, the site of maximal pain is marked out and an additional distal medial portal is established. A K-wire is inserted under fluoroscopic guidance to provide the surgeon with direct endoscopic visualization of the osseous resection level. A shaver or burr is used to resect the deformity, ensuring thorough removal of both osseous and periosseal layers to minimize the risk of recurrence. At the conclusion of the procedure, dorsiflexion and plantar flexion of the ankle are performed to assess smooth gliding of the tendon. Achilles tendoscopy can also be performed using a 1.9 mm 0-degree needle endoscope, which is the preference of the senior author. The technical steps of the procedure when using a 1.9 mm 0-degree needle endoscope are almost identical to using a 2.7 mm or 4.0 mm 30-degree endoscope, with slight modifications to the perioperative local anesthetic block. This procedure can be performed in both the office setting and in a formal operating suite. Benefits of using a 1.9 mm endoscope include: the smaller diameter of the endoscope reduces the trauma to the soft tissue envelope, thus reducing the risk of wound complications and facilitating rapid return to work, activity, and sport. There are limitations associated with the 1.9 mm endoscope, as currently no 30-degree endoscope is available.